If you look at the list of countries with the best healthcare systems, you will see Canada, Sweden, Singapore, Australia, and more. So how do they compile such a list? It refers to its effectiveness, availability, quality on healthcare. Another thing is the expenditure. This is one of the reasons you won't find the USA on the list even they spend almost 80% of the GDP on healthcare, which is the highest in the world. Getting sick in the US can bankrupt the family. Statistics shows that around 650,000 Americans go bankrupt yearly because of the medical bills, and the former President Obama said that there was a medical bill-related bankruptcy in US every 30 seconds in 2009. That's 1 million medical bankruptcy in a year. About the rural healthcare situation. US is the third largest country in the world with a total area of 10 million square kilometers. Nearly 97% of the land is considered as rural. The US Census Bureau defines rural as any population, housing, or territory not in urban areas. About 60 million Americans live in rural areas, which is 20% of its total population. With the worldwide first ranking for its GDP, 19,000 trillion USD and about 10,000 per capita, while the healthcare in rural areas still a concern in terms of both service and outcomes. About the healthcare service. First, the urban community hospitals are 2 times set in rural areas regarding the American Hospital Association in 2018. Another problem is the shortage of physicians in rural communities. 20% of about 5 million rural residents live in shortage area with less than 33 primary physicians per 100,000 residents. This imbalance grows over time and the healthcare disparity gap exceeds, where 100,000 rural Americans could only share 65 primary physicians, which is 40 fewer than the urbans. Greater distance result in longer wait time for the rural emergency medical services, and hospital reviews state that the waiting time for the rural areas is 120 minutes while the urbans is 10 minutes in average. It was said that if you were bleeding an extra 15 minutes, you could probably die. Ongoing shift of patient care from the inpatients to the outpatient setting is commonly found in rural hospitals have led to declining occupancy and lacking About 37% of all rural hospitals lost money compared to 32% of urbans under financial strain. Remote rural residents' reliance on public insurance programs demonstrate lower family incomes and older population. Residents who were uninsured under the age of 65 was 14% of populations, while in urban areas was 13% in 2004. Also, only 59% of workers in rural areas are offered employer-sponsored health insurance. Less than half are covered when compared with 69% in the urban areas.
When it comes to health outcomes, generally residents in rural areas are often older, more ill, and have a higher mortality rates than other urban counterparts. According to a study in 2014, mortality rate in urban areas only took up 700, while that of rural areas is 800 in terms of age-adjusted rate per 100,000. Rural Americans were 50% more likely to die from some specific diseases. There were 4,000 deaths from stroke, 11,000 from CLRD, 19,000 from cancer, and 25,000 from heart disease. However, those deaths are preventable. It is clear that the US rural health system is inadequate in service delivery and health workforce. The commitment to the Sustainable Development Goals SDG 10 that ensures equitable access to health services for universal health coverage based on stronger primary care, telemedicine is our suggestion to the US government due to its potential to heal the rural health system by enhancing service delivery and increasing health workforce in rural areas. Let's see how it works. As defined by WHO, healthcare services delivery that's using information and communication technologies for the exchange of information for diagnosis, treatment, and prevention of disease, as well as injuries research and evaluation, also for the continuing education of healthcare providers. The global telemedicine technology is mainly driven by the incidence of chronic diseases and life-changing conditions. Telemedicine is bridging the gap of the vast unmet medical needs by offering clinical healthcare without the hindrance of distance. The 3 primary methods of telemedicine are real-time communication, store and forward, and remote patient monitoring. Real-time communication allows patients to connect with providers via video conference instead of long-distance traveling. It enables patients to exchange information with healthcare professionals and receive care in their own places, which dramatically reduces the transportation time and cost, hence improving access to health services in rural areas. Eventually, it brings the physician workforce from urban to rural areas to resolve workforce shortages. Even the access to specialty can be facilitated, like telestroke. Doctors specializing in stroke care at distant sites can work together with EMS doctors at originating sites to handle patients in rural areas. This allows patients to stay in their communities while receiving specialized treatment. The second one is remote patients monitoring, which refers to the electronic transmission that tracks patients' healthcare data by a remote healthcare service provider. Diabetes management and prevention is a typical example. Physicians at distant sites can use remote patients monitoring to keep track of patients' chronic condition and to deliver care quickly. This feature offers better care to chronic disease patients in rural settings. The last one, store and forward, refers to the transmission of clinical data, images, or video from one care site to another for evaluation. For example, e-referrals enable a physician to discuss a patient's case with other medical specialists before an in-person referral. Therefore, it increases the appropriateness of referrals to tertiary care and reduces time spending on redundant evaluation and diagnosis. When concerning with the challenges, since additional licensure is required for providers who are cross borders, licensure of providers can be a problem. We suggest that state medical boards provide compacts to facilitate a licensed physician to apply for licenses in other states. There are also different Medicare reimbursements across the states because of geographic restrictions, provider eligibility, and types of telemedicine modalities. So we suggest that the government set up a platform for the patients to keep track of their medication records. It's also a problem of poor broadband networks. Many rural areas do not currently have stable internet connections, so that we suggest the government provide annual funding to improve and expand rural area online connectivity. There are also other practical issues like technology barriers, lack of computer literacy, and privacy and security. There are some take-home messages, including the first one, the situation of rural health. Rural residents face a variety of access barriers, which causes the timely use of personal health service. Second one is the strengths of telemedicine, which can resolve the shrinking and maldistributed workforce in rural areas and improve specific chronic disease management. And the third one is the limitations, which includes the reimbursement, licensure, and poor broadband network problems, which will continue to be issues of policymakers.